I'm one of, and I've been really transformed. This is my first APNA conference, and you guys have done fantastic. I've spent a lot of my time at educator and renal conferences. I'm a renal nurse by trade. I fell into academia by mistake, but I'm called an anti-academic by some of my colleagues, but also a bicultural troublemaker, which means I can sort of fit into the clinical world and the academic world and cause trouble. And I am planning on causing some trouble in the primary healthcare world today. A couple of things first. I just want to, I've been picked up with why I've used the word authentic e-learning in this presentation. You know, you guys ever sat down and done e-learning, like for your code of conduct, where you sit down there and you just go next, 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 do the 5 questions and hope you get them right? Yeah, so authentic e-learning, I'm sick of that. I go, why do we spend all this money developing e-learning programs when we know that we can see the data that says, yeah, you spent 7 minutes on this, but you're supposed to have spent half an hour for your CPD, and yeah, that's really just not on. So authentic is that we actually use a case study base. There was a lot of interaction in it. And this is actually part of a much larger study called the CKD-DETECT study, where there was multiple outcomes, but the core outcome that we actually looked at was behavioural intention, because I'm sick to death of seeing e-learning programs come out and say, oh yes, we can improve knowledge, or we see outcome factors where we say, do you feel more confident doing ear irrigation? It's like, I'm not interested in how confident you are. Do you think I'm really confident up here speaking with you guys at the moment? Yeah? No, I am. No, I'm shitting myself, but you know, that's okay, because I've had to follow, you know, cave diver dude, which is really quite phenomenal. So I want to do that. So I was really ballsy, and I thought that I was going to get up here first and be able to talk to an animation, but last night I might have drunk too much, and only in the last half hour has my urine turned from dark yellow to white. I'm a renal nurse. I can talk about we quite comfortably. That's okay. And so I decided at the very last minute there was no way I could try and talk to this animation off the top. So instead you're going to hear me recorded. Oh, there's that technology. So how prevalent is CKD in Australia? So let's call this the healthy Australian population. Of these people, epidemiological studies have shown that 1 in 3 are at increased risk of chronic kidney disease because they possess one or more of its known risk factors. So approximately 1.7 million Australians, that's about 1 in 10 aged 18 years and over, have indicators of CKD such as reduced kidney function and or albumin in their urine. Fewer than 10% of people with CKD are actually aware they even have it. This means that over 1.5 million Australians are unaware they have indicators of CKD. This is pretty significant considering the kidney and urinary tract diseases are the 9th leading cause of death in Australia, killing more people each year than breast cancer, prostate cancer and road deaths combined. CKD is a strong risk factor for future coronary events and all-cause mortality, even more so than diabetes. So fewer than 10% of Australians with CKD are aware they even have it. This is largely because up to 90% of renal function can be lost before any symptoms are experienced. If CKD is detected early and managed appropriately, then the otherwise inevitable deterioration in kidney function can be reduced by as much as 50% and, in some cases, may even be reversible. Practice nurses can play a valuable role in making this happen. Really so let's move on to the next page and meet John Anderson and learn more about opportunistic CKD screening in primary care. Okay, so what you've actually just seen is the very first introductory page of the actual e-learning program, and I'm really glad that I didn't actually try and do that all off the top of my head. One of the things that you hear is there's this real challenge that we have is that kidney disease is rather a largely a silent disease. And in Australia, we actually have no idea what the sort of knowledge is of practice nurses. We don't even know what the knowledge is of GP, you know, in terms of background knowledge of understanding who's at risk and what we should do. So what I want to do is I want to go through... So how prevalent is CKD in Australia? That's supposed to be happening. So let's call this the healthy Australian population that they were talking about. Okay, so what we did is we did a big RCT, and Denise Lyons said to me, do not baffle them with... Is Denise in the room? No, she's not. she said, don't sit there and go all down the track of heavy research. So I'm going to avoid that. So I want to speak in a language you guys can understand nice and easily. So we did an RCT, and all I'm going to present on today is the impact of the asynchronous e-learning program on general practice nurses' knowledge about CKD, risk factors and screening practice. Now the reason why we said asynchronous, so asynchronous means it's an e-learning program that you can attach any time that you want. You can complete any time you want. One of the big challenges that we have, particularly with people in rural and remote areas, is that they can't access the education that people in metro areas can. So by having asynchronous e-learning programs, they can access it any time. Okay, so these are the participants. Basically, any nurse who was working in general practice setting or who had worked in one within the last 12 months, they were eligible to participate. So this was a randomized controlled trial. Okay, now this is the only part you're going to have to think. Okay. So what happened is we consented everyone and then we randomised them to the active control or the intervention. The intervention was behavioural intervention. Today I'm only going to talk to you about the knowledge one, okay? But what we thought is there any use actually getting people who are doing the intervention, the behavioural one, getting them to actually go through all the behavioural if they actually don't know about who's at risk and how to screen for kidney disease? So what we thought is we're just going to put the pre-knowledge test and ask them to do that. And if they get less than 75%, we're going to get them to do the module that was just about knowledge, which was actually our active control. But if they got greater than 75%, we're not going to go putting them through something they already know. That makes good educational sense, yeah? So do you think 75% is a good benchmark for a pass mark? Okay, you're all happy? Remember that. Okay, so what we did is now this is a randomised controlled trial. So normally we would separate them and all that with our data. But we actually, because everybody went through the same pathway, yeah, we did the analysis of what we call a pre-post intervention. So we just pulled everyone in together. We actually looked at them separately and there was actually no difference in results. Okay, so pre-post test evaluative design. We gave them 12 questions, all right, at the beginning. Did anyone actually do this by chance? Anyone remember doing this? Okay, thank you for doing it. So, you guys, this is the first time you're going to see the results of how you went. Okay. So, but what I'm going to get you to do first is I'm actually going to show you some of the questions that we did and see how you go. So this is the first screen that everybody saw, okay? So I'm going to give you one question. I'm going to give you three over the session, okay? In Australia, the most common factor that leads to the need for dialysis or a kidney transplant is what? Have a think in your head. Have a think. Rightio. You got the answer in your head? Did you get diabetes? No? You didn't? Okay, well, sorry. I'm not going to sit here and try and embarrass anyone. Okay, so I'm going to give you an idea of where we got. So don't get too crazy on this. We had 212 people in the whole study, right? Really interesting, years in working, pretty experienced, yeah? What was quite interesting also is even though they'd been working in nursing, we'd actually noticed that working in general practice might not necessarily have been as long as they were working there in nursing as a whole. But the other thing that was really interesting is that 121, so 57% of the cohort had never undertaken any CKD education before. So we thought, oh, okay, that's something we need to be mindful of. Okay, here's another question. According to best practice, the kidney health check consists of what? Okay, you got it? Okay, you ready? Who picked that one? Did you all pick it? Right, blood pressure, definitely we're checking for hypertension, right? All right, now, there's a trick here because is it a urinary dipstick for protein? Is it a microalbuminuria dipstick? Is it the ACR or is it the APR? Or is it the EGFR? What was that, what? The ACR? Okay. Did you guess that one or did you know it? Did you go ACR because that's what we do in diabetes cycle care? Okay. And is there any more? Is that it? An EGFR. Okay, you guys, that's pretty good. Okay, let's ask you another question. Miss Jones, a 65-year-old Aboriginal woman. She weighs 80 kilograms, a BMI is 31. She has a history of diabetes, hypertension, smoking, COPD. Which of the following are CKD risk factors? Okay, I've got to finish this. I've got 15 minutes. All right, you ready? You ready? You got it in your head? Did you get 2 and 3? You should have done the study. It would have been, the results would have been a lot better than what they were. Okay, you ready for it? All right. Here are the results. Okay, don't get too stressed because I'm actually going to square them. So what happened is we actually had 12 items, but 2 of the items, 8 and 11, we removed them because only 2 and 5% of people actually got them right. So we're like, oh, okay, we're going to remove them because they didn't discriminate very well. So here's our score. So we had them modified, so we dropped down 10. The baseline score was 3.7 out of 10. So 37%. That was for everyone put together. You know that 75%? That's pretty ordinary, isn't it? Can you see how we started off with 212 in the first batch, and then in the next lot we had 208? Do you remember that 75%? 4 people. 4 general practice nurses got over 75%. 2 of them got 100%. I'm sure you were one of them, Michelle, and there was probably some renal nurse that did the other one. Might have been me just testing. No, I don't know. It wouldn't have been, because we don't do that. But can you see, we actually broke it down because there were 5 questions relating to risk factors and 5 questions relating to screening. So around risk factors is actually quite poor. But this is the kicker, right? This little p-value thing, that's what tells us whether or not it's statistically significant, okay? And in this type of research, and anyone who's an academic out there will stone me later for saying this, I think this is all bullshit because of this. Once I can sit here and go, hey, e-learning, statistically significant, absolutely fantastic. We could improve general practice nurses in Australia with a well-powered study, and we could improve it to show statistical significance. See this here? That's the follow-up score. They went from 3.7 to 5.48, so their score was 54.8%. What was that benchmark that you all agreed that 75% was sound? We still weren't great at the end of it. So, wow. Okay. So this is why I'm saying this stuff here doesn't mean anything, because clinically and in the real world, it's actually quite a concern still. Because even after doing a targeted e-learning program, we still couldn't get it up to a benchmark that we thought was appropriate. Okay? Oh, there, I have another one. Okay. So I told you I got here to this is my first conference, and I was pretty amazed. And I had all this stuff to say about what these results mean and what we should be doing and all that sort of stuff. And I actually went last night before I started drinking beer, and I changed this whole slide. And my slide is this. Because you guys talked about this thing, about this value, being valued, being visible, being respected. And you talked about, and some of you may or may not have gone in and done the pledge and looked at, I will take charge of my career. I'll promote the value of my role. I'll support my profession and my peers. How am I going for time? Am I good? Yeah? 4 minutes, okay. That's all right. The challenge I want to put to you is because I know what the risk factors are for kidney disease, and I know how to do a kidney health check, but I'm not the one who's out there seeing patients every day. And one of the things that to me is not openly obvious about the pledge here is that the patient's not front and foremost there. But I can understand that if you're going to promote the value of your role, the value of your role has to be in person-centred outcomes. And me being one of those tertiary nurses who's so used to all the money being thrown at us, and we've got all of this support, and in my case, all the time in the world, it's very hard if someone comes in complaining of carpal tunnel-like symptoms, and you say, oh, actually, you're 80 kilograms, you've got diabetes, oh, you're hypertensive, your BMI is, 32, I'm just going to do a kidney health check, because that's not your world, is it? So the challenge for you guys from me today is not that you guys need to learn more about chronic kidney disease, because when you walk around upstairs, you see that you've also got to manage palliative care, you've got to manage all these other comorbidities that we were talking about earlier, that it's no longer that, and we become so task-centred. So it's about looking at the patient in the whole, and you guys are fantastic at that. But the job now is to actually start to change the model of care that gets delivered, and I think that's something maybe this pledge will help us over the next 4 years. So, as I just wrap up, we actually decided now, instead of going and doing more postdoc work around behaviour, we figured we need to do some serious work on trying to get the message out of what the 9 risk factors are for kidney disease, and also how to do a kidney health check. Now, you guys obviously are all fantastic, but what we're going to do is we're going to do CKD-DETECT version 2.0, where we're actually going to compare doing the e-learning program versus an infographic, because there's no data out there. We're using infographics an awful lot with education and health promotion, but we don't actually have any evidence whether they're actually any good. So that's the next step. So you're going to be with almost through ethics with it. We've just got a little minor variation we've got to make, and that's going to be coming out through your primary health networks and all that sort of stuff. So finally, as I just wrap up, I just want to acknowledge Denise and Tony Isaac from Katara Family Practice. When we did the e-learning program, the intervention, we actually went into their practices and filmed how they were doing things. And so people who went through it could actually say, these are the challenges, and they could hear Denise or Di from Shoalhaven talk about the challenges. But also, Briony Robson and the whole team at Kidney Health Australia, you'll see a lot of when we did the animation, we used all of the graphics that they had already created to be able to create these animations. So if you've got any questions, feel free to grab me afterwards, particularly if you want to talk about the study or anything like that. I'd be very, very happy to have a chat with you. So thank you all. Thank you.